Good afternoon. First of all, I hope to give a dry eye lecture, not a dry eye lecture this afternoon. I'm a surgeon, so I like to keep things very, very simple. And also as a surgeon, I don't always do what you expect me to do. So I'm actually not going to talk too much about treatment. I think you may find more specifics about treatment opportunities from the lecture I gave 2 years ago. And the BEBRF has a copy of that, and you can get as many copies as you want. But I'm going to touch on some of those aspects. I'm going to talk more about, in general, the way treatments are going. So let's see if I can get this to work. So treating eye disease, I put treating in quotes and eye disease in quotes because I'm not really going to talk about treating. I'm going to talk about ameliorating, making a little bit better. Okay. So types of blepharospasm. I'm going to run over a bunch of things that we've talked on before. Again, I'm trying to simplify, and sometimes hearing it a little bit different way will make things a little bit clearer. So there's primary benign essential blepharospasm. And there are several kinds, the spastic, the apraxic, and combined that was talked about before. And there's a secondary, and you heard a whole list of some of the secondary causes of blepharospasm: tear film problems, eyelid abnormalities, entropion, ectropion, conjunctival disease, corneal disease, scleral disease, and intraocular disease. And then there are complex secondary, which are multiple of those factors together, and habitual. So we're not going to talk about these, and I'm going to talk about primary and secondary as really being one entity. I find it very hard to separate those. And we're not going to talk about all these other things, the intraocular disease, the scleral disease, the corneal disease, especially if I can't get this to work. And let me just say a quick word about cause and effect. There was a question asked earlier today about whether a chalazion can cause blepharospasm, and the answer is, of course, no. And that was, the answer was given you. But we are always looking for underlying causes, and one of the things that frequently causes multiple chalasia or styes in young adulthood is posterior lid margin disease blepharitis, and people that are particularly predisposed to that will also be predisposed to significant. I don't know what I did, something exciting. Will also be predisposed to ocular irritation. So let me see if we can back off of some of this stuff here. Thank you. So we're really going to talk about how secondary tear film problems contribute to primary benign essential blepharospasm, again along the same lines as everybody else has been talking about, and then talk about different treatment options. So here is my simplistic view of this world. Here's your eye, here's your brain, and the brain tells the eye to blink, and sometimes the eye tells the brain to tell the eye to blink. In the normal person, you might have some mild irritants, and it says to the brain, I'm having some mild irritation, and nothing happens. That's the average person. In the blepharospasm patient, or person, you have mild irritants, and it tells the brain, hey, I'm irritated, and the brain says, blink. And I think that's along the lines of what we've been talking about this morning. And again, this is a very simplistic view. You have the eye, I think this is a screwdriver, you stick it in the eye, and the eye will blink. And you can do that with any irritant. And the irritants that we're talking about are things like allergens, pollutants, tobacco, smoke, toxins that you might get from other drops that you put in your eye that have things that you're allergic or you find your body finds toxic. And pollutants are increasing every day in our environment. Even tactile breeze, the breeze dries your eye, but also the touch of the breeze, the blow of the breeze itself can stimulate your eyes to close. Bright glare, and I think you'll hear more about that later. Eyelashes, entropion, distichiasis, trichiasis, all those crazy names we heard about earlier where the eyelashes are rubbing on the eye. Wrong spectacle correction. Even this can stimulate blepharospasm. We've had a couple of patients that were blepharospasm patients doing very poorly, and we got a refraction on them, and they did a lot better. And then this concept of dry eye. So this is a thing that we saw before a couple of years ago. Here's the eyeball sitting in the eye socket. And there's tear production, and then there's tear outflow. And this is the normal system, and hopefully the outflow and the production are about the same, and so the eye stays lubricated. And here's the system in the actual person. You have many glands, but the primary one here is the lacrimal gland I'm showing, but there are some 60 glands. And they produce tears. It washes over the eye and drains out through the tear drain system into the back of the nose and throat, which is why when you cry, your nose runs. So too little production or too rapid outflow will give you a dry eye. But that's not just what we're talking about. The other problem that we see with blepharospasm patients, or I see, is that when your eye dries out, there's a system built in to lubricate your eye some more. And you get this compensatory over-lubrication of water tears. And I find that most of my blepharospasm patients are missing this. So the average person, when their eye dries out, their eye actually then starts to water. Most blepharospasm patients in my practice don't. One thing that you'll find that is frequently offered to blepharospasm patients who have dry eye is we'll do punctal plugging. We'll close up the tear drain, keep more fluid on the eye. And I'll try to convince you in a few minutes why that can be very problematic. Okay, dry eye is not a good term, and I think that you've heard that before today and you'll hear it again. Dysfunctional tear syndrome is perhaps a better term. And I would encourage you to think about this as a whole host of different diseases, all with the same endpoint. So just to review some of the basics of tear film, here's the eyeball. Here's the outside world with all the irritants. There's a water layer which gives you the biggest bulk of protection for your eye. And that's the powerhouse of the tear film. It's got all kinds of nice things in it, proteins and healing elements and things that will kill bacteria. It's really the good part of your tear film. Then there's the mucin layer, which allows the water component to stick to your eyeball and go smoothly over it. And then there's the lipid layer. Now, you heard a little bit earlier about how if you don't have a lipid layer, your eye dries out. And if you aren't convinced of that, get 2 glasses of water, put them in the kitchen, fill them all the way up, and in one, just put a tiny bit of olive oil in it. Come back a week later. The glass that has a little bit of oil in it will not have evaporated away at all. So this is a barrier. It prevents the evaporation. And again, just so you can understand the complexity of the tear film, we've shown here the 3 different layers, but it's not really that. It's more of a smear across the whole tear film. But the 3 basic components are important to remember because you can have diseases affecting any one of those 3 layers, which will then affect your eye. And they talked a little bit earlier today about staining. What they were talking about is these little cells here. This is a micrograph or a picture of a micrograph. So these are the cells that line the surface of your cornea, and when they dry out or get irritated, inflamed, they will die. And the good thing is that we make them very quickly. We make them all the time. But when they die, you now have these nerves that are exposed, and that's very painful, very irritating. So how do you know if you have a tear film problem? Well, a couple years ago I told you how to tell, but now I say everybody probably does. We all probably have a tear film problem, and it's increasing with frequency and increasing with severity. We have increasing environmental pollutants everywhere. Decreasing androgens and estrogen levels as we get older, or the ratio certainly changes, and the absolute androgen level will change in most of us, even the women, which is why, in particular, women postmenopausal have a problem because their ovaries make androgens. Tear gland demise over time. All these billions of, well, not billions, but 60, 70 tear glands that we have in our eyes, these get killed over time, and we'll talk a little bit more about that in a minute. Increasing frequency of autoimmune disease. we've touched a little bit on autoimmune diseases. There are some 80-plus autoimmune diseases. Once you have one in your family, you're at higher risk than the average person for all 80. They are inherited. You heard about autosomal dominant inheritance. Most of them are autosomal dominantly inherited. And they're increasing in frequency in the population. And these things specifically will target the tear-producing glands. There are several of these diseases where it's been clearly shown to do that, and many of them will present with a dry eye problem. About 30% or more of all medications that you take will decrease your tear quality and your volume. So you can see that we're all at increasing risk for dry eye over time. And these are just some of the quick medications that we'll do: blood pressure medications, cholesterol-modifying agents, anticholinergics, antidepressants, heart rhythm stabilizing agents, Parkinson's disease agents, antihistamines, and many, many others. And of course, if you're putting topical drops in your eyes that have preservatives in them, they may also be affecting your tear production. So I want to kind of nail down this concept in everybody's mind. You have a bunch of things that predispose you to an eye irritation or dry eye problem. And I want to take away that idea of dry eye. This is not just dry eye. This is bad quality tear film. And this creates an irritation in the eye. The irritation in the eye leads to an immune activation. That just means that your body says, boy, we got a problem, and it starts reacting to it. And that creates inflammation, and inflammation leads to more irritation in the eye, and you get into this vicious cycle. So I just want you to get this concept of things that irritate your eye. It creates inflammation, like if you fall over and skin your knee, you get inflammation on your knee. Here you get inflammation on your eye, and it creates more irritation, and you get this vicious cycle. So these three layers of the tear film that we talked about are made by different kinds of glands in the eyelids and on the eye surface. And inflammation that we just talked about kills all three of these types of glands. And I say it kills the glands, and actually in some cases it actually destroys the glands. But in all cases, it decreases their activity. So it decreases their ability to work. So inflammation in the eye is bad. And this shows you the lipid layer that's broken up, unstable, and it gives us a toxic tear. Why does it give us a toxic tear? Why is the tear bad when this starts to break up? Well, it turns out if you take oil that you normally keep in your refrigerator and you put it out on the counter, it will go rancid. The same thing is true with the oils in your eye. They go rancid. And rancid oil in the eye is very inflammatory to the eye. Tear evaporation, I'll show you a little bit more about this in a minute, but there's all kinds of toxins that we have in our tear. Remember, the tear overlies cells that are doing what they're supposed to do. They're making things, they're being cells. And one of the things that cells do is they create waste products. Every cell in your body makes a waste product or makes a bunch of waste products as it's doing what it normally does. It's like a factory. You put stuff into it, it produces what it's supposed to do, and there's waste product. Those waste products hang out in the tear film and get washed down into your tear drain into the back of your nose and throat. If your volume of water, your water component, is decreasing, then the concentration of those waste products, those toxins, increases. That should be very clear to everybody. You're not increasing the number of toxins, but you're increasing the concentration because the volume that they're in gets smaller. And so now you start getting a toxic tear problem. And I think this just illustrates that point. Inflammation decreases tear production. As this evaporates away, the same number of toxins are now in a smaller volume, and now they're more irritating to your eye. So there are three areas of research and development to treat these syndromes, and we'll talk about them pretty generally. The first is this thing that we've talked about before, where in blepharospasm patients, these mild irritants turn the brain on, and we had a very nice discussion about that earlier today. And this is where we really have to get some change if we're really going to make an impact on blepharospasm. We've got to understand this better. These guys are working very hard on this, and when we do understand it better, there's the potential to turn this cycle off. The second thing that we need to do is we need to manage the toxic tears that we all have. So as your tear volume is decreasing, you're increasing the number of irritants in your eye, you've got this toxic tear. And so there's two things that we do. The first thing that we do is we use supplements to dilute out the bad tears, so add more water into the mix. And the second is to provide a more healthy tear supplement to the eye. So this is supposed to depict rinsing out that bad toxic tear and putting in tear supplements that will rinse that out and also protect the eye. I hope this is pretty clear for people. Different types of lubricants and washes. They fall into these basic categories. I'm just going to list them for you. And what I'm trying to tell you is that there are all kinds of tear supplements out there, and I've only listed some of them. And we aren't smart enough, I'm not smart enough to tell you which one is going to be best for whom. And it's kind of pick and choose and see what you like and see what works well for you. And if you work within a particular group of these tear supplements and you're not having much benefit, you might try a different one, because everybody's toxic tear or reason for tear film abnormality can be different. And you might find actually that you need a combination of these. So now you understand why you might try different kinds of tear supplements and why you might try a combination of different tear supplements. So these are all cellulose-based tear supplements. That's just the name of the stuff that's in there that keeps it on your eye. These are glycerin-based supplements. These are both glycerin and cellulose-based. Here are some oil-based and glycol-based. And then we also have these inserts that you can put in that will hold things in even longer. So you can understand how you know better than your doctor what makes your eye comfortable and why different drops might be good for different people. Okay, I think we've touched on this already. We've told you, be careful about getting your eyes plugged. If you have a toxic tear and you haven't solved the underlying problem that's creating your toxic tear, whether it's an eyelid inflammation or whether it's a diet problem, whatever it is, and I don't want to go into all of them right now, but if you haven't solved that, then you're not going to make yourself happier by putting in a plug. You're going to keep those toxic tears on your eye. For many people, it's more beneficial to leave that drain open so that those bad tears get washed out more easily. But then you have to use the supplements to rinse them out. Here's an interesting question. If you have toxic tear and you use one of these thicker tear supplements, does that hold the toxins on your eye more? And in some patients in my practice, the answer is yes. So in some patients in my practice, they need to try the thinner tear supplements. And contact lenses, which can often be used, bandage contact lenses or the Boston scleral lens, for some people are problematic because it keeps the toxins more on your eye. Is that clear to everybody? Any questions about that? Okay. Interrupting inflammation. Well, I've told you that inflammation is really important in this whole process. You start getting inflammation from the irritation, and it damages the cells even more, and it creates a bigger problem. We are currently in the infancy of treating this problem. I'm reminded of rheumatoid arthritis, which is an inflammatory disease. And 30 years ago, we had two drugs. We had gold and Plaquenil. Do we have anything else? Anybody remember back 30 years ago? So we really didn't have and steroids. And today, we have a huge array of very, very specific immune-modifying drugs for rheumatoid arthritis and other autoimmune diseases. They haven't made their way into the eye yet, but they will. And currently, we are today dealing with the eye the same way we dealt with rheumatoid arthritis 30 years ago. So we have some early immune modulators, advanced specific modulators, and interrupt underlying disease. This is basically the three things that rheumatoid arthritis has done, and this is where we're headed, and I'll show you where we are in this process. So interrupting inflammation. Oils we eat. There are other things that flaxseed oil and omega-3 oils do, but one of the things they do is they decrease the inflammation in the eye. And I would strongly encourage everybody in this room to be taking both of these. And let me just say a quick word about how you take these. First of all, if you're going to take omega-3 oils, make sure you get them without mercury. And there's many companies that make it, but I particularly like Carlson oil. But get whatever you want that's inexpensive, that doesn't have mercury in it. And also take flaxseed. Now, flaxseed is interesting. Flaxseed oil will dissolve the capsule that it's in, so they make the capsule extra thick. And so if you take flaxseed oil by capsule, it will have passed through the majority of people before that capsule dissolves, and you'll not get any benefit. So if you want the benefit of flaxseed oil, you ought to take the actual oil, make it into a salad dressing, do whatever you want. But you need to take the flaxseed oil as an oil, and it's synergistic. That means it acts extra good if you use it with the omega-3 oils. And if you use a sulfonated peanut butter at the same time, sulfonated protein like peanut butter, soy, or turkey, these things will increase dramatically the absorption of both of these oils. So if you don't eat a sulfonated protein at the same time, you only get about 20% of the benefit. If you do, then you get much more benefit from the oil. So don't take it with a capsule, and do take it with a sulfonated protein. Non-steroidals. There are a couple of non-steroidals that are currently available. The Toradol is currently available for the eye, Nevanac or Acular. This other bromophenec is being investigated. Corticosteroids are currently available, and oral tetracyclines. Let me just say a quick word about cyclosporin. Cyclosporin is a chemotherapy agent. I won't go into all the bad problems about it, but I would encourage you to think twice about using it. There are much better ones down the road. Let's see what else we have to say. I think most of these other things are on the previous talk that you can get from the BEBRF. I want to just say a quick word about the Boston scleral lens. If you haven't heard about it and you have a real problem with moisture, this is a great thing to think about if you can get your insurance company to pay for it. It is a hard contact lens that covers the entire eye and is really good for people who have a severe moisture problem. There are some new therapies coming down the line. They are not here yet. Okay, I think I'll leave it at that. Thanks very much.